So we're going to cover 4 cases today and try to relate them to evidence. And Aaron and I worked on this jointly but separately and didn't rehearse. So if Aaron joins in, he can, or when he's online, he can decide when he wants to intervene. Neither of us has any conflict to disclose. We don't accept any pharmaceutical money. And the learning objectives, I think, are to try to think a bit more about when we should rethink the individual indications and contraindications to either aspirin alone or antiplatelet drugs combined. Get some sense of the approximate probability that someone would benefit or be harmed by any such treatment. Appreciate that most of the benefits may occur early after one starts treatment or after a clinical event like a myocardial infarction, a stenting procedure after acute coronary syndrome, or a TIA or a stroke. The benefit may be early, and know when to stop platelets, and using a few examples to explore that. So here's one that Sydney submitted a few weeks ago, where the question really arises, could clopidogrel be stopped 8 years after percutaneous coronary intervention with stents? And she ran across this in Dawson Creek in a man who had about 8 years ago undergone stenting for a non-ST segment elevation MI. And then the left anterior descending coronary artery obstructed 6 months after replacement of a stent. So this would have been a crisis, potentially lethal. And he had a repeat intervention and restenting. And there's diabetes, high blood pressure, obesity, ongoing smoking, and perhaps a rather high hemoglobin might, that large high mean cell volume might also reflect obesity and fatty liver, or a number of other things. And he's known to have negative tests for occult blood in his stool and good kidney function, but he's on a lot of drugs, including both aspirin and clopidogrel. The question arose, could one stop it? And I think I won't ask Sydney to comment right now, but she might want to later. But this was opposed by a specialist. So one answer is you could respect what the specialist said, who says, no, keep it up, it's too dangerous to stop. Another is to look at evidence and try to understand the evidence. And I think one of the easier ways might be, I tried this against a friend of mine who's a very good cardiologist at UBC, and he sent me back the most recent Canadian Cardiology Society guideline, which he refers to. Another is to try to look further at evidence. So if you looked at that guideline that my friend sent me, the recommendations, it's a very long document, which is very hard to read, I found, but they boil down to this. For a year after percutaneous coronary intervention, dual antiplatelet therapy, barring some catastrophe such as a severe hemorrhage, of course, or if you die before 1 year, you wouldn't carry it on. And for up to 3 years, depending on the clinical judgment of the situation, and then aspirin indefinitely, if you're not otherwise taking an oral anticoagulant, brackets, or bleeding. I put bleeding in brackets because they don't say that. They don't actually in their guideline accommodate for some issues that I'm going to raise. The Cochrane review, that's the closest review, is published in 2017 and is less definite. And it says, if you boil down a very long document, up to 1 year, the results showed that there is a benefit of adding clopidogrel to aspirin to reduce the risk of heart attack or stroke. However, there's a higher risk of major and minor bleeding associated with this. And there was no effect on death due to heart problems or death from any cause. So looked at that way, the Canadian recommendations are essentially telling us we could avoid some important clinical events, but it's not necessarily going to keep us alive, even up to 1 year. I think the Cochrane is a little bit less strongly worded than the cardiologist put it. Okay, but this patient that Sydney was looking at, has diabetes, doesn't that make all the difference? So let's back up a little bit and think about what we know about primary and then secondary prevention. Now, there's a lot to choose from. So Aaron came up with some of the presentation, and I came up with some, and we've tried to summarize it in a way that might make some sense. So here's something relatively recent from just over 2 years ago. Large trial in people who have diabetes and are not known to have coronary artery disease or cerebrovascular disease. There are plenty of people in this. They were enrolled rather a long time ago now. If you think certain things have changed in treatment, but at that time, many people might have been getting statins as well. And it's a standard dose of aspirin. It happens to be 100 milligrams because it's done in other countries. The mean age is very similar to Sydney's patient. It's all, the mean BMI is also rather similar. And the difference in serious vascular events over an average of 7.4 years is 1.1%. So this translates into around a number of about, 90 people treated for 7.4 years. One of them would avoid a serious vascular event, but 110 people treated for the same period would have, one of them would have major bleeding. So it's not quite as different as one might think. The total deaths are not different. They numerically favor aspirin, which is nice, but from a point of view of proof, they're not statistically significantly different. So one would be preventing, if you gave aspirin to someone with diabetes in primary prevention, one has a small possibility over a long period of time of preventing something unpleasant, but also of causing something unpleasant, mostly not bleeding in the brain. That's important to realize. Gastrointestinal hemorrhage can be awful, but it should very rarely be lethal. And here's another thing that's just published. I guess I forgot to put the date on here. This is only, and the reference, this is only 2 years ago. This is Aspirin, another very large study, slightly more recent, 19,000 people, followed up to 6 years, somewhat older, and looking at the composite of death, dementia, or persistent physical disabilities. So these were, I like this title, disability-free survival. That's what people like Charles and I would be looking at it, at least at my age. There's no difference between placebo and aspirin. In fact, aspirin was numerically slightly higher, but they're equivalent. And actually, this is reassuring for someone like Charles or me because it's only 2 out of 100 people over follow-up of about an average of about a little over 4 years. Only 2 out of 100 end up with something rather nasty like that. So we still have pretty good odds, Charles. Now here's a second case. This is one of the ones I've encountered in Chatland. A 76-year-old who has type 2 diabetes. He's got treated high blood pressure. He's being given primary prevention treatment to prevent atherosclerotic events, presumably because somebody thought this was a good idea because he has diabetes. And his blood count is normal. And my initial opinion was I wasn't sure why he needed metoprolol or aspirin. I wasn't big on the sitagliptin either, but it was going to be much more of a battle to persuade him not to take that. So I started with this. So that question arises, well, was that a good idea or a bad idea to tell that 76-year-old? So let's look now, let's focus specifically on primary prevention again. There's some very new evidence. This was just published on January 21st in print and a little bit earlier online in New England Journal of Medicine. This is the famous cardiologist Salim Youssef who promoted ramipril in the, I'm blocking on the name of that famous trial with ramipril, is Salim Youssef, and he's run a number of other large trials, and he's particularly interested from McMaster University in prevention in less wealthy countries where people don't get a lot of health services. So similar to a study that was done in northern Iran a couple of years ago, this one was done in 8 countries, mostly India, Philippines, Malaysia, and Indonesia. And it's a substantial number of people. It's not huge. It's middle-aged people. Women are more than half of the people. Mean age is 64. These are people he used a scale which is something one could apply without laboratory measurements, based largely on age, family history, blood pressure or not, diabetes or not, and waist size compared to hip diameter, hip circumference, waist versus hip. They were given either a polypill containing simvastatin, hydrochlorothiazide, ramipril, or atenolol, or placebo. And then in a factorial design, they could also have aspirin or placebo. So this can tell us something again about aspirin in primary prevention in people who are a bit higher risk. I tried the Interheart score myself, and at age almost 70, with treated high blood pressure and a dad who probably had an MI around in his late 50s, early 60s, I came in at, I could have probably qualified for this trial. So these results might apply to me. And if you look at the aspirin versus placebo comparison, which is about half the people in the trial, almost 3,000 versus almost 3,000, the difference, the absolute risk reduction is 0.6%. Over what was that? Over 4.6 years. So if I were to apply this evidence to myself, 167 people like me taking it for the better part of 5 years, one of us would avoid a stroke. So it's not useless, but it's a small effect. In that case, they're mostly Asian people. And interestingly, just for comparison, if you take the polypill and aspirin versus placebo, there's a more substantial effect. It would be 59 people, but it's still not a huge effect. So I think this is quite relevant to anyone who's sort of frightened that, you know, I really don't know what to do. It's Friday or Thursday, and I can't make up my mind. I'm terrified something horrendous will happen if I suggest the person might want to stop this. It gives you an idea of the magnitude of the effects, which could be useful in a population. But right now, I think you would choose, if you were in India or Indonesia or somewhere, you would choose COVID vaccination, one shot, over the polypill for 4.6 years, if you're worried about being healthy. So now we'll come, Aaron pulled this. Are you there, Aaron? Or if so, speak up and you can take over if you want. I guess not. Aaron pulled this from RX Files, which is something I haven't tried to use. I found it rather complicated, but for those of you who like it, interesting, they come up with this bottom line. There's no compelling evidence to use aspirin for individuals who don't have a history of cardiovascular or cerebrovascular disease in primary prevention. And they say in particular, avoid aspirin for that purpose in people who are over 70. So once I get past May 1st, somebody will spare me from being recommended aspirin according to this. Or if you're at low or moderate risk of CV events and so on. Then they summarize it this way. They point out in the table that the only situation in which the benefits appeared to counterbalance the disadvantages was in people who also had diabetes, which is what I just showed you. And the absolute risk increase for serious vascular events roughly counterbalances the absolute risk increase for major bleeding. Although major bleeding can be something like a 20 gram per liter drop in hemoglobin and not more. I'm not familiar with the details of the definition in that study, but it often is defined as that, and 20 gram per liter drop is not in itself catastrophic most of the time. Some people wouldn't even notice it, right? So here's another way to look at this. This may be useful for people who are facing this again in the clinic. And oh my God, I remember vaguely that these treatments weren't that wonderful, but I've forgotten completely the numbers. The NNT.com is a useful place to find probably reliable information. Emergency doctors in Harvard University do this. And they come up with something very similar for preventing a first attack or stroke in primary prevention. Their numbers are a little bit different. They say, they don't give us a length, a duration here. They say 1 in 133 people would benefit, and 333 would benefit, and roughly the same number would have a major bleeding event. So I think the other sources are somewhat better, but if we look at what about right after a heart attack, a major one, a STEMI, it's a much more significant benefit. 1 in 42 were helped, as in their life was saved. And only 1 in 167 had harm from non-dangerous bleeding. So this is quite compelling. If someone says, look, if you don't take this aspirin right now, you're going to die, they're exaggerating, but it's still pretty darn useful for a simple treatment. I'm going to show you in a moment that this happens, most of the benefit happens very fast too. Now, if we compare that with secondary prevention, the NNT gives us a figure for, wait a minute, I think I put the wrong label on the top here. Ignore that. This is aspirin to prevent cardiovascular disease in people with known heart disease or stroke, but who are not in the midst of a serious MI. About 1 in 50 to prevent a cardiovascular problem, about 1 in 333 to prevent death. And the harms are relatively modest in this assessment. So I think the problem is, nobody, you can see already, oh my God, why is he presenting so many numbers? How can anybody remember these? And I don't think that anybody could reliably. Here's clopidogrel alone. I think maybe I accidentally mislabeled that, but clopidogrel alone is very similar. And you can find this, if you wish, simply by looking at the nnt.com, searching clopidogrel. Aaron, if you wish to take over, let me know. I see you're there now, but on the other hand, I just skimmed through that and we want to have some discussion too. So this is the first case being represented. So this is Sydney's case, and if Sydney wants to say something, I guess this would be a good time if you wish, or the rest of the audience.
It was more so just uncertainty. I wasn't familiar with any of the evidence past a year to 3 years at most. There was the complication of this patient who had occluded his stents, I think, within the 6 months of having them. So I didn't know if that impacted the recommendations. So I was really curious to hear what you found and what your suggestions were on it.
Yeah, Aaron, why don't you comment in a second, but I'll just say what I know, that every time I've confronted this issue, it's impossible to answer that because there will be no evidence applicable to people whose stent obstructed after 6 months. And then we're re-randomized to say, well, we better start again from scratch. Let's give this person another year of dual-antiplatelet therapy. Or let's say, we're going to feel compelled to do that because we have evidence that dual-antiplatelet therapy on balance is a little bit better than a single drug for up to a year. But beyond that, in the general population, we have evidence that it causes too much harm. However, in someone who just wrecked their stent, let's do it for a year again and then re-randomize such people, so-called maybe stent obstructions or failures, dual-antiplatelet failures, if you wanted to use the old terminology that was used to sell clopidogrel. And they said, well, so-and-so is an aspirin failure, they better take clopidogrel instead. We would call this, in that false terminology, a failure. Now let's re-randomize to either 1 year or 3 years. But probably no one will ever do a study that goes for, 8 years or 7.5 years. So it's inherently unanswerable, and it really would come down more to clinical pragmatism. What if it blocks off, is there any harm being done, which you don't show any evidence of? Or alternately, is it very expensive and clopidogrel is now generic and not very? Or is there a compelling reason to fear another obstruction, like he lives in Dawson Creek, and if he obstructs, he can't just go down to the local hospital to get a new stent put in? Do you want to comment, Aaron?
Yes, sorry, I was having trouble connecting. I'm sorry for being late. It's the evidence is, when we looked at it, and when I just recently updated myself, it's the trials only tell you so much, and the benefit appears early. Just one general principle to remember, that if you look at this slide where it says the benefit, 1 in 50 were helped, so the number needed to treat is 50. Just reminding yourself about what does that mean about the other 49 people. So the other 49 people, some of them will go on to have stent thrombosis or an MI or whatever the event is that you're worried about, and some of them won't. Only one can be known to be saved from having that event from drug therapy. The other 49, again, some of them will have the event or some of them won't. So this idea, if someone comes back with a stent thrombosis or an MI after being on dual antiplatelets that the drug failed, isn't logical based on these numbers. Right? You would never be able to tell in the patient in front of you. And the only way would be to do an experiment where you re-randomize people that came back with a stent thrombosis, so which is unanswerable, essentially. So it's not, you're more likely to not get the benefit than you are to not have any effect from the treatment, with the odds of 1 in 50.
I went back to our own Therapeutics Initiative website, because I think actually it's probably one of the easiest ways to answer this question as of 2009, when many more, drug-eluting stents had just really started to become quite common, not too long before that. But a major study was called CURE, C-U-R-E, or CURE-PCI, a study of clopidogrel added to aspirin. And we had working with us in the early 2000s a Costa Rican internist who came to do a PhD. He was a very logical, clear-headed thinker named Jose Arguedas, who looked carefully at the New England Journal of Medicine article and noticed, oh, look at that. The half of the benefit occurs in the first 30 days after an event, in this case, an acute coronary syndrome, in which people received in the emergency department or the cath lab a loading dose of clopidogrel and then 75 milligrams a day plus aspirin. And actually an awful lot of that half benefit occurs in the first 24 hours. But when I understood that back in the early 2000s, after Jose sort of walked us through the CURE trial, it's one of the only times in my career I've ever been an early adopter and started giving the loading dose of clopidogrel to people in whom I suspected acute coronary syndrome in our emergency department at UBC, thinking, yeah, I would take it myself too, because an awful lot of the benefit occurs just after the loading dose in the first 24 hours, and very little harm can come of that. And then you've got to spend the remaining 8 months or longer of dual antiplatelet therapy to get another half of the benefit. So at that time, with a relatively expensive drug, if you'd been resource constrained, you would have shared it around and made sure everybody got it for the first month. And the problem is that about also half of the major bleeding occurs in the first month, but another half occurs after that. So really you're still kind of balancing good with bad, and the big news happens in the first month of such treatment. I don't know, do you know that with the more modern drugs, Aaron, whether it's similar with ticagrelor or prasugrel, whatever they're using?
When I looked at ticagrelor or prasugrel a couple of years ago, when the two big trials, one for each of those drugs, came out, I didn't look at I don't think there was that kind of breakdown of the events over time. So I wasn't able to do that kind of analysis. So.
You can see it a bit here. This is the graph from of major adverse cardiovascular and cerebrovascular events. I didn't show you bleeding events from so-called DAPT study in New England Journal of Medicine 7 years ago. And here I've blown up just that part of the graph. This is itself blown up compared to this one on a scale of 0 to 100% cumulative incidence. So here the scale is 0 to 8% over a period of up to 33 months after the event. And for the first 12 months, everybody gets both aspirin and a thienopyridine. And then after that, the blue group get placebo and the green group get dual antiplatelet therapy. And you can see that the separation of these two lines here where my cursor is really about the same as it is here. You could argue it's a little bit different there, but up here it's even less. So really it's somewhere, I think this is probably where people ended up coming to the conclusion that, you know, let's compromise on 18 months rather than 3 years.
Tom, sorry to interrupt. I don't see the slide with the graph. I'm still on the NNT clopidogrel slide, so I don't know if it's just my Zoom or everyone's.
People saying, I think I'm sharing my screen and it should say, here's the basic issue for DAPT.
Yes, I can see that, Tom.
Okay, it's my issue then.
Must be your internet connection, yeah. So here's a summary from RX files, which is very similar. If you have a stent for stable coronary artery disease, say bad angina, and you get a stent, or someone says, well, you know, that one, if that one obstructs, it may kill you. You think you should be stented. Dual platelets for 6 to 12 months. After an acute coronary syndrome, a non-STEMI or a STEMI, 12 months. After a non-cardioembolic stroke, non-cardio as in not atrial fibrillation, 21 days. Or after intracranial artery stenosis, I'm not sure if this refers to something requiring an intervention like a PCI or a radiological procedure, 90 days. So in the cerebrovascular disease, it's actually shorter duration is thought to be optimal. You prepared that slide, Aaron. Do you want to say anything more about that one? If you can see it. I think we may have lost him. In the Therapeutics Initiative, we published this letter in about 6 years ago now, in which we summarized everything published up to that time and concluded, actually, if you're thinking about being alive, long-term dual antiplatelet therapy compared with aspirin alone, long-term, doesn't change your chance of being alive, and then it increases your chance of dying in some settings. And it's definitely indicated after an acute coronary syndrome, should be started immediately, continued for a maximum of a year. Most of the benefit occurs in the first 30 days. That's what I showed you from a much more detailed analysis. If you want it, you can find on our site. And you'll all have this presentation, so you can look up the links easily enough.
Just if I can add, the interesting thing, I know there's more ticagrelor evidence now than there was back in 2015, but at the time the claim was that it's better than clopidogrel or prasugrel because it reduces the risk of all-cause mortality versus those drugs. This is one example of where our assessment of what the US FDA had seen from submitted documents by the company, that the claim was hard to believe. For example, the reviewer at the time noted that when he went through all the case report forms, there were a number of people that reported their own deaths according to the case report forms, and the number of people that had missing vital status information was several-fold higher than the number of fewer deaths in the ticagrelor group. So at the time, the FDA was not convinced that ticagrelor offered any advantage for serious events versus clopidogrel, and in fact increased the risk of bleeding, leading to the final bullet on this slide that at the time, and I believe still, RX files and the NNT.com also support this idea that there's no clear advantage of using the newer antiplatelets.
Yeah, I once also reported my own death, but the report was apparently substantially exaggerated. Mark Twain said that about other people reporting his death. But this is, do you want to speak to this, Aaron? I think it's kind of a useful summary slide. Does this come from RX Files or somewhere else?
The summary slide, again, I can't see the progression of the slides, but it's the one that talks about if someone's on long duration dual antiplatelets. That's from RX Files. And it's a useful tool. Excuse me. Their summary on this topic is quite good. It gives you reasons why a specialist would consider long-term therapy, reasons why a specialist would consider triple therapy, and what do you do when you see a patient on some on dual antiplatelets for more than a year. These are the questions to ask. So unless there's a documented compelling reason from a specialist, they're suggesting that beyond a year is potentially more harmful than it is beneficial.
Aaron, what is triple therapy?
When they add an oral anticoagulant.
Ah, okay. 2 antiplatelet drugs and an anticoagulant.
Mm-hmm.
Yeah. So I'm going to switch to a slightly different issue, which is, when we must reassess the whole patient, which is, as an internist, this is something that has troubled me for quite a while because I think I've saved the lives of a number of people who otherwise would have died had I not looked carefully. Here's an example of one of them, whom I met about 4.5 years ago, and he's still alive now. His GP had quote unquote retired, in fact, changed to working in a nursing home, and may have had a letter from the College of Physicians about opioids because he just basically dismissed the patient and said, I'm not going to prescribe for you anymore. And he had been prescribing slow release oxycodone for a very painful groin injury from hernia repair, sort of quote unquote neuropathic pain. And this patient had been stented 7 years before I met him. He had the usual aspirin and clopidogrel probably for a year, I don't know how long. He was known to have diffuse atherosclerosis. When I examined him, he had aortic stenosis and probably aortic regurgitation, which often goes along. He had I think femoral artery bruit, or he was known to have carotid artery bruit. So as is commonly the case, the process of atherosclerosis was diffuse, and he would have been at much higher risk than the average person for stroke, as well as myocardial infarction, or even, for that matter, aortic aneurysmal dissection or rupture. And he was known to have had a bleeding peptic ulcer before that was thought to be associated with an NSAID. He was still smoking, had COPD. This was another potential risk factor for him, significant BPH, and he'd been anemic with iron deficiency for a year before I met him. So there he's on, in this case, only 1 antiplatelet and nothing else commonly assumed to cause bleeding. You might wonder about sertraline perhaps, but the big issue if he had iron deficiency would obviously be aspirin. Oops. And when I met him, he was referred to me because he'd gone to a GP who knew me and thought maybe I would agree to prescribe an opioid for him, when his own GP had refused to. And looking at him, he was very pale. He had significant aortic stenosis. He stank of tobacco. By that time, it was becoming very unusual for anyone to smell of tobacco at the UBC hospital clinic. And he had an alarming anemia that day. I didn't actually know this. I set things in process and told him to stop aspirin, but that night he went to his local hospital and they measured him on the spot and transfused him. And I could see it was coming because he had a low hemoglobin the year before. It had dropped I was able to get these records through Care Connect. And a year and a half before I met him, he had a ferritin. So here's an example where if someone is taking a drug known to increase the chance of bleeding, whether it's aspirin or another antiplatelet drug or an NSAID or an anticoagulant of any kind, one should always pay attention to the hemoglobin and the iron index. And usually the ferritin is the best. Once in a while, iron studies are more useful. But, you know, he's got severe iron deficiency here because his mean cell volume has dropped dramatically, and he's got, on the lab then did its usual microscopy and said it looks like he's got iron deficiency anemia. So, you know, why was that ignored? I don't, you know, there are any number of answers how that happened to this poor guy, but he's at extremely high risk because of his vascular disease, his aortic stenosis, his lung disease, and aspirin is probably the cause of this. So that night in Abbotsford, I think he was transfused. They showed that he had ulcers. I tried to persuade them to give him some intravenous iron while he was in the hospital and caught them just as they were discharging him. And the hospitalist said, yeah, oh, that would have been a good idea, but we've just discharged him. I managed to set it up later, and he had stopped the aspirin as of when he left my office, but of course it was still working for a week or two after the day I met him. And then subsequently he's done very well. He's had this aortic valve implanted, he's on apixaban, but he's still leaking. And, oh, I guess I forgot to put it in there. I meant to add a more recent hemoglobin. He's around 122 now, and his mean cell volume is okay, but his ferritin is 22. So all the iron that has been given to him intravenously has been consumed to keep making blood. He's a guy with significant COPD. He should normally have a high hemoglobin, and he's low for a man. These are all warnings that an ongoing leak, but at least he's not on aspirin. So here's a case where you might want him to have stayed on aspirin because of significant cardiovascular risk, whether you think it was for the stent or just to prevent stroke or heart attack, and yet it's too dangerous. And I think that's just kind of a reminder, always look in anyone on a long-term antiplatelet or anticoagulant, always look at the hemoglobin and the ferritin. Any questions about that while we're on that one? Then I'm going to move to another Chetwynd patient. So this is the fourth case. This woman, the description in their EMR is rather limited, and it came sort of this way: GERD-no esophagitis, hypertension, quote, chronic kidney disease. I don't think that's in fact true, and type 2 diabetes. And, you know, when I say glycoside and metformin, I'm willing to believe, I guess they probably have type 2 diabetes, whereas I'm much more suspicious of this label in everybody, because as soon as you get below 60 mils per minute calculated EGFR, you get that label on it. It may not mean anything. But more important, she was said to have a TIA in those records, and she told me when I interviewed her by Zoom that she had fallen suddenly about 7 times, as she put it, while crossing a room, which would have been at age 79. And I think the nephrologist in Prince George seems to think she has a subclavian steal syndrome. Charles can probably tell us what that is. I had to look it up and remind myself, but it suggested maybe somebody thought she fell because she had a shortage of blood supply through the vertebral arteries, which would be called vertebrobasilar insufficiency. It didn't make any sense to me that 6 years later, nothing else has happened. And I guess you could say, oh, yes, but that's because she's been on aspirin. But here she's got ferrous gluconate for some reason. I don't think I knew her hemoglobin or her iron status, but somebody thought she was iron deficient to recommend that. And it shows up in PharmD, so it's prescribed, and she's on aspirin, etc. So should this person stay on aspirin or not. Before I show you some evidence, does anyone want to comment on this? Or should I say, well, she's very elderly. She's on gabapentin, which may be causing her to be off balance now. Anyone who's 85 has significant risks of falling. I want a better reason for aspirin than just a suspicion that she might have had a TIA, which was impossible to prove. And do we know if you're 85 that the advantages outweigh the disadvantages the same as if you're 65 or 55?
The gabapentin and the gliclazide, both of them could cause TIA type symptoms. The gliclazide, I mean, I've just never liked gliclazide in the elderly, especially because they can get hypoglycemia and they can do funny things as well. So she's being put onto a drug for 6 years and seemingly forever for a possible TIA, but no real definite evidence for it. So it doesn't quite ring true to me.
So you might, Dr. Helm might go with your gut and say, you know, where this is a polypharmacy reduction project, we're going to try and get rid of the gliclazide if possible and the gabapentin, which I think I did. I certainly asked her to get rid of the gabapentin. I don't think this lady I've followed up yet, but
yeah, and I mean, there's other stuff there as well. There's, you know, if you were to get rid of the aspirin, you might be able to get rid of the PPI.
yeah,
she might not need the ferrous gluconate, which might be constipating her if she's off the aspirin. And there's all sorts of possibilities there. I mean, the aspirin is one of them.
Yeah, I'm forgetting now. I think I called for some repeat lab tests because there wasn't anything very fresh in this woman, and then planned to follow it up, and it hasn't happened yet. But here's what I could find that's relevant.
Not to mention the statin without, it seems to be primary prevention statin aged 85.
Yeah. There's quite a bit that it was joyous to attempt to clean up a bit, and she thought it was too many pills too. But if you try to find evidence about this, what about antiplatelets if you're trying to prevent ischemic stroke or TIA, which would have been the case in this woman's instance? There is a brand new review. These reviews are very complicated, but I've taken the summary of findings and put the red box around it. And you can see, well, if one accepts what they found for treatment up to 1 month only, this evidence applies to people who are treated for a month, which I think must be the same thing that was referenced in the, I'll just go back to it quickly,
the RX files, the table.
RX files, yeah, it's this kind of information here. Can you see these now, Aaron, by the way? Or not? I went
no,
back.
but someone suggested I look at your original PowerPoint.
You can
so that's what I'm doing.
So here it's similar, up to a month. Well, 2 out of 100 fewer strokes. No difference in vascular deaths. In this case, one more myocardial infarction, oddly enough, and 25 fewer 25 fewer of a composite outcome, but 2 more intracranial hemorrhages per 1,000. So they end up saying multiple antiplatelets. This doesn't directly apply to that 85-year-old woman because she's only on aspirin, but multiple, there would be a small reduction in stroke recurrence in the first month after stroke, but an increased risk of bleeding. And they conclude, this is the plain language summary, there 2 are slightly better than 1, but there's an increased risk of side effects. They started immediately after, if you start them immediately after a stroke, they seem to outweigh the risks for the first month. So
Tom, if I may add, it's interesting I don't know when patients say they're concerned about having a stroke, what if they all mean the same thing. So are they worried about intracranial hemorrhage or ischemic stroke? And so that evidence you're showing applies to a reduction in non-fatal ischemic stroke. And they don't really say exactly if it's disabling or not. But it also comes with an increased risk of intracranial hemorrhage, which some patients may view as bad as a stroke, or in their mind, that is a stroke. So, it's hard to tell what patients value or is important to them without asking them, because the evidence sometimes isn't clear.
Yeah. Now remember, this one is for multiple versus fewer antiplatelets.
Mm-hmm.
So this is not relevant to aspirin alone. And I'm afraid we've got that somewhere buried in the rest of this presentation, I guess aspirin alone. But in this case, if a patient were taking 2 antiplatelet drugs to prevent stroke, the Cochrane review that's brand new from the Cochrane Stroke Group concludes, for the first month maybe, which is actually not all that different from what I showed you from the so-called CURE, C-U-R-E, and CURE-PCI studies of adding clopidogrel to aspirin. The major benefit was in the first month after an acute coronary syndrome. So that's actually, I think there's time for discussion, or alternately for going for supper.
Can I just make one comment, Tom?
Mm-hmm.
So getting back to the aspirin for primary prevention, or the dual antiplatelet summaries with clopidogrel and aspirin, if you note that the effect is different, the number needed to treat is different if it's a non-fatal MI or a stroke. It can range anywhere from 50 to 200, the same for different types of toxicity. And I was just reading some information about patient preferences or perceptions, and the discrepancies that exist between their care providers, and how there's more often discordance in value judgments between providers and patients than you would think when it's been studied. So prescribers tend to value the all-cause mortality information more than patients. They're more concerned about things like bleeds. And so again, if they've been started on an antiplatelet many years ago and now you're dealing with them and they were told something about it reduces your risk of a recurrent event, but they don't know the details, and the MI effect is not important to them, all they're concerned about with stroke, they may come up with a different decision whether to stay on it or not, depending on that clarity. So what I'm getting at is sometimes we think we know what is the patient would find the most important and the proper motivator to take something, but we may be wrong. So it might be a good idea to occasionally check in and say, what is the outcome you're most concerned with? And then I can tell you what is the likelihood of that intervention having an impact on that risk, and see if those two things align.
I'm just trying to find the chat again in case there are questions. Aaron, do you wish to show the ticagrelor slide or not?
Well, we can show it. Basically, it's the NNT.com's interpretation of all the evidence, more recent assessment, and they echo our findings from our letter, which is it's questionable advantage over clopidogrel, but clear excess harm versus clopidogrel. So although it's claimed to be the better antiplatelet to add to aspirin, not everyone is convinced that it is. That would be the only point.
I don't know, Raina, if you're seeing anything different in the chat. I'm not seeing very much, except that Christy Demeter evidently didn't feel like dancing today. But for those of you who came late, if you want something that'll just kind of cheer you up, check out that YouTube song. We were playing it before we started.
Tom, just the way we've been at a practical level, when we get people on aspirin, these are often folks that when Sharisa and I see them in our medication assessments, these are often people that I myself would have put onto aspirin 10, 15 years ago, because at the time, the recommendations and the evidence really did seem to support, especially for diabetics, putting, it was just like our standard of care. Diabetics, everyone would be on aspirin unless there was a contraindication. And I don't think we've had much pushback or resistance when we say to them, look, we're going with the evidence. We know that what we're telling you, it's the best we can do at the moment based on the evidence. And yes, things could change in future, but at the time, it seemed to be the right thing to do. And right now, the evidence just does not really support us doing that anymore. And in fact, the evidence, shows that there's a possibility of harm. And Sharisa, I don't know if you want to comment on that, but one or two people have said, no, I want to stay on my aspirin. But the majority have said, no, that's fine. We respect, if I can get off that one, that's great. And yeah, we've also seen a few cases with actually more with the anticoagulants than with aspirin, but with alarmingly low hemoglobins.
Yeah, I don't think I have anything to add to that, but yeah, it's funny that people kind of feel like it's a security blanket that they don't want to get rid of in some cases. And if they're not experiencing any adverse effects, it's hard to convince them otherwise, but it's good to bring it up.
Yeah, I wouldn't personally be bothered very much if somebody wants to continue aspirin that's very inexpensive. If they don't have easy bruising, they have a nice hemoglobin and no evidence of iron deficiency. It's important to remember that the hemoglobin is preserved until the bone marrow exhausts its iron stores. So one can bleed slowly for a long time and still have a fairly nice hemoglobin. So if you're thinking about that, the way to make a diagnosis is to suspect bleeding in anybody taking a drug that causes bleeding. And there are some drugs like SSRIs that probably do increase bleeding, but that's not where I would jump. It would be antiplatelets and anticoagulants and NSAIDs taken continuously. And just to always check periodically a ferritin. And of course, maybe aspirin makes it easier to diagnose colon cancer or stomach cancer, and if you're doing fecal blood testing, but I don't believe that's known. I think people probably have done provocative tests with aspirin, and I don't think it's known that it makes it any more sensitive. It's just if you find bleeding, it's not necessarily the aspirin causing it, but in case whether it's the aspirin causing it or the clopidogrel or the ticagrelor or the anticoagulant or something else, you're probably going to want to, when you can, you're going to want to stop those drugs until you know, because somebody may be coming to surgery soon. And the sooner you get rid of the aspirin, the sooner they can be operated on safely. I think we've covered everything we hope to, and there are no easy answers with this, but the bottom line for me is kind of don't lose sleep. If you suggest to someone then they might want to stop their aspirin, it's not going to make a huge difference one way or the other, even in a population of hundreds or thousands of people.
And for dual antiplatelets, anything over 12 months is reason to reassess.
Yeah. Any other final comments, or we can sign off and go have supper?
Tom, I just remember that Ulrika Meyer at one of, I think, our previous webinar, she's got a great memory, and she pointed out that at Tom Finucane at the 3D conference, well, 2 years ago now, I guess, was the identical recommendation. Mm-hmm. Benefits in the first year, you can kind of stop the dual stuff after that. That was Tom Finucane's message to 3D. and Ulrika plucked that out of her brain somewhere, which I'd forgotten, but it seems to be very consistent with what you folks are telling us.
It's good.
Okay, well, it's nice to see everybody that we could see, and see you again before too long.
Yeah, thank you, everyone.
Good night.
Thanks, folks. Thank you.